Hello and welcome to the Auditing Antics podcast. So I hope you're all having a good week so far and that April Fool's Day was not too cruel to you this year. Michelle and I had some pretty funny voice messages from our niece after our call out last week, which was pretty entertaining. So it was a fun day for us.
It was. She's such a little stinker. And, nobody successfully April Fool's her. So
Yeah. Well, she
she's
kept
just too
calling it
smart.
April
April
Fool's
Fool's
and
and
yeah,
are
yeah.
you April Fool's and me? Kids
Yes,
are
it's
hilarious.
she is the young one still. She's just 7, so she
hmm
gets to still do some fun things like that with us. The teens aren't really into it as much
Well, the
anymore,
thing
so
is she still thinks we're cool. The other
yeah.
ones are like, you're very weird. Please go away.
Yeah, we gotta hold on to that.
Unless we have money for them.
Yes, yeah. Yeah, they will go shopping, so we'll see,
Yes.
but
I think she's more expensive than the older ones, personally.
oh, the joys of being an aunt.
Yes.
All right. So this week we're going to be talking about risk adjustment. And, it's pretty interesting, Michelle, that I received the email and got to look over that Optum communication earlier this week when we already decided we were going to talk about this.
Yeah. Perfect timing.
Yeah, yeah. And, that communication really just frustrated me. I was just like, is this for real? Are we really going to be dealing with this? And to just give a quick overview, I did write an article about it this week. You can find it on my website or on LinkedIn. But basically, Optum is reaching out. Now, this is saying it's a part of their Medicaid plans, but they're reaching out and stating that they're doing provider claim reviews. And within these reviews, basically what they're doing is they're going back through the patient's chart and they're sending snippets of what they're calling a pseudo claim to the providers and saying essentially, please review. We would like you to update and add these diagnoses in to complete the patient's health picture. Yeah.
So,
There's so many things wrong with this.
when you say they review the chart, are they reviewing past encounters or only the encounter that the claim is for?
So that's the thing. They are looking at the patient's chart information. They're not only looking at one date of service and what was addressed on that day. So
So,
when they're reaching out to these groups, they're saying, we've reviewed, everything that you've submitted to us. And remember too, another thing I can't help but to think about, and I don't think this is the situation in the letter that I saw, but remember Optum is a part of that massive monopoly, we'll call it, with United Healthcare. Maybe not a complete monopoly because there's other people in the industry that are doing the same exact thing like Aetna that United Healthcare has done, where they own bits and pieces of everything. They own
yeah,
Optum, they own Change Healthcare. There's so many, arms that they have that it's just ridiculous that they're allowed to be in every part of the healthcare system. So when we see this coming from Optum, it's interesting because remember last year we had found out that Epic was partnering with United Healthcare to start giving insurance companies like United Healthcare access into Epic so that they would have full view of what's going on in the charts. So it's like this type of thing is exactly why I had an issue when we heard about that last year. And
yeah,
now we see that they're going to continue to pressure providers. And Michelle, my biggest concern here is not just the pressure, that really annoys me, but
mhm,
separate from that, think about how much we have or how many times we have situations that come up that providers will just deal with because they don't know what's being said truly. Or they'll
yeah,
say, well, Optum's asking, this must be something that we have to do, and direct their staff to go in and fix it. And maybe that staff isn't really trained. Maybe that staff doesn't have proper support to know that they shouldn't be doing that.
yeah. And One thing that is especially concerning is we already see a really high error rate related to the diagnosis coding when we're auditing. So adding this on top of it is going to make it really difficult for those of us trying to get out there and provide the education and ensure compliant claims are going out the door. It's going to be impossible because then
Mhm.
that the clients are gonna come back and say, "Well, Optum said we were supposed to add these diagnosis codes." And it's like,
Right,
"Well,
right,
no, you were to review
right.
to see
Well,
if
and
they've occurred."
that's the thing too. They're basically saying as well that, they'll put the disclaimers in there that it's up to the provider to make that decision. But does the provider really understand? Because a lot of times with risk adjustment, and this is what I think you were referring to, we have that problem where they just add things in because they think that that's what we're asking for. Just add as
Mhm.
many diagnoses as you can get in there, and then compliance, coding, auditing, whoever it is going to be satisfied based on the data that's in the claims at that point.
Yeah, it's it's quite frustrating to me. Sometimes I feel like a broken record. In fact, today I'm working on an audit where the diagnosis codes that were reported, half of them aren't even addressed in the in the note. They're basically just listed in the assessment, and there's no
Mhm.
documentation to show how they were treated, if they require treatment, if there was further workup related to them, or did they affect patient care on this date. Nothing. So it's already frustrating enough without adding this on top of it, because they think that just by putting them in the assessment, that
Right,
that and I think some of this comes from that acronym of MEET,
right.
that monitor, evaluate, assess, address, treat.
Yeah.
And just because it says assess doesn't mean listing it in the assessment is
Right.
sufficient.
Right. Well, and one of the things that also bothers me about this coming out from Optum, again, owned as a part of the United Healthcare umbrella. This specifically, the letter that I saw is for Medicaid. But if we think about United Healthcare and Medicare, they've already been in trouble. There's been, different information and reports of reviews that they've had. I think it was in 2025. You can easily find it online. But the Medicare division of United Healthcare was in trouble because they were going out and doing things like having home risk assessments done, trying to
Yeah.
maximize diagnoses by people that were employed by them. It wasn't even like it was these patients' practitioners. They would employ, probably a nurse. I don't even think it was a licensed provider. And they were going out and doing home risk assessments and using that information to submit diagnoses. So, as a part of that, they've already been warned that they've been trying to inflate what it is that they're doing. And, they've been using somewhat aggressive tactics, right?
Yeah.
And this is just another version of that. But unfortunately, this is pushing it even more onto the provider's back, which is very problematic.
Yes, it is. This brings me back to to my first coding job, and the value-based team was looking at improving our HCC reporting.
Mhm.
And the higher ups in our department decided the answer to this was just entering every diagnosis code that the hospital coders, so the inpatient coders, added to hospital claims. So we would
Mhm.
hold discharges until the hospital coded the hospital stay, and then we would put that entire list associated to the discharge claim for the provider for the professional billing. And it's like that was just wild to me that that was the solution. And then we get emails, wow, we've seen a this percentage increase in our HCC code reporting. It's like, well, no guarantee that's accurate. That's
Mhm.
I don't I don't know if they still do that. I really hope they've updated that process, but
Yeah.
I just remember that, and that came from, the pressure of trying to improve reporting, but really it needed to come from the providers. We were not a 100% code review organization. Most of the claims were going out the door
Mhm.
without being looked at. The providers were coding them and out they would go. So it's just interesting some of the methods people come up with to try to improve this HCC capture.
Yeah. Yeah. Well, and that's the thing. It's like if we look at everything as a whole and we look at, everything that we've done from an education standpoint, from an auditing standpoint, and that feedback, we've always had this back and forth between the entities that are looking to maximize risk adjustment and those of us that are looking at it from the provider's perspective and what's supported in documentation. And I can't help to think about the fact that we have, nowadays, and I'm even seeing it in some of the UPIC audits that I'm working on, they're not risk adjustment specific. But one thing that's interesting to me in that is I'm starting to see that CMS, for example, is pulling and making denial comments related to claims data that they have pulled as a part of the audit review. So you may have one date of service that they're wanting to audit or multiple dates of service that they're wanting to audit. But in addition to the issues that they state that they found with those sets of dates, there's also denial comments related to the diagnoses that they've
Mhm.
seen in the past in billing patterns. Also, references to CPT codes. They're pulling it to see, okay, the patient already had, like with skin grafting, they're saying the patient had the skin grafts done at such and such a time. Why did you do it again in 2025?
Mhm.
So that was another thing too when United Healthcare on the Medicare side of things got called out by DOJ, OIG, all of that. They were stating the same thing in that home health risk assessment done by who knows, probably the nurse.
Mhm.
They were pulling conditions, but then they were never seen again on a claim throughout that entire year.
Mhm.
And I don't know, how this is going to play out, but to me, the fact that I'm seeing those types of things referenced and then knowing that most organizations are pushed to, for example, do an annual wellness visit and try to capture as many diagnoses
Mhm.
that you can in that one annual wellness visit. I've done a lot of work with like ACO organizations and PACE programs where they are looking to maximize and capture. But especially in like an ACO, they do tend to have more of that model where they're looking to maximize at the annual wellness visit. So then my question is, okay, now as an educator and an auditor, am I even going to have to worry beyond that? Maybe they
Mhm.
did a good job in the annual wellness visit showing something about that. But what if they pull claims and then they never see certain conditions again, or over the span of 2 years they see it mentioned twice and never
Yep.
again? I think that that's going to be even more challenging as we move forward.
Yeah, and I find it interesting in the annual wellness visit, for example. What I tend to see is you can get 20 plus diagnosis associated to that. So to me, that's telling me the provider is just blowing in a problem list and then putting what they think they need to in there. So was it really meaningfully addressed by the provider? Was it just put there for show? I,
Mhm.
I mean, does that make sense? Is that that's
It does.
a pretty big assumption, but you and I have both seen this pattern where the problem list is being overutilized and it's not accurate. Nobody has gone in and updated that problem list in the past 2 years. We see it in just everyday diagnosis code reporting as well, where it's incorrect specificity is
Mhm.
reported on the claim. And then when you look at documentation, it says something different. But you and I both know those diagnosis codes are driven from the problem list, so nobody went in and updated it.
Right.
Um, so it's not just about the condition being documented. It's about, was it meaningfully addressed and considered by the
Mhm.
provider? And I think that is often the piece that is missed. It's not just about saying, like, one this is one of my biggest pet peeves, and I see this all the time, is in the note you will see other specify or diabetes with other specified complications, and they're reporting E11.69. But
Right.
there is no documentation of a complication. But they're reporting E11.69 because that has a higher risk adjusted score or is a more specific code. But
Mhm.
it means nothing because there's no complications in documentation that can be related to the diabetes or assumed, have that causal relationship assumed. So it's about more than just the words being in the note. It's
Mhm.
about, what did you do with it, and does your documentation actually support it?
Yeah.
And I think that's a really big frustration point for me, is it's very clear and evident that the education that's going out there is is maybe not being understood. So maybe it's not the education, but maybe it's, like you said, the provider that thinks they're doing what you want them to do
Right.
instead of really applying what you've asked them to do or taking the time to understand what you need them to do.
Right.
Because I think if they had a clear understanding, it wouldn't be this.
Well, that's why you have to break it down too. And there's a lot of times, like I mentioned, I work a lot with different ACO groups. So an ACO is a larger organization, an accountable care organization that is made up essentially of mostly smaller private practices that collectively have this goal together as an organization, kind of going towards a little more of the value-based care side of things, which can largely go into risk adjustment. So the thing that I find is when I work with organizations like that, the providers are incredibly overwhelmed
Mhm,
because, think about small practices. They often don't want to reach out and get an audit done. They don't want to pay for additional input. They don't even typically want to pay, to have staff that are well versed in what they're doing from a billing and definitely not a coding perspective. So that all comes together in a situation where they're finding out, oh, I'm a part of this group. I have these different requirements that I have to meet because I'm a part of this group, and they're
mhm,
asking me to do X, Y, and Z. So when it's so overwhelming, you've got to break it down so that it's more digestible. And maybe in the first round of reviews, there's one area that you're focusing on with each group individually, trying to get them to improve. Just depends on where everyone's at. But a lot of times there's a lot of deficiencies when looking
mhm,
through that type of audit work. Now, as a part of the questions, Michelle, for every practice that they should be asking, just in general about risk adjustment, what you brought up was really good. I think everybody needs to be asking the question of how is your problem list set up? And then taking it a step further and looking at it from the perspective of your EMR system. So, does your vendor have different things that are built in that allow your providers to click a button and
mhm,
every diagnosis the patient has ever had, or every diagnosis on an active problem list gets blown into the billing, or
mhm.
I should say, actually blown into the assessment in the note, which then transfers to the billing.
Yes. It's it's a huge issue with
Mhm.
across many different types of
Yeah.
EHRs.
A lot of the systems have
It's
that
not
capability.
just it's not just a problem we see in Epic. I mean, the audit I'm currently working in is all scripts.
Yeah.
And that's, that can be
Mhm.
a
Epic,
similar
NextGen,
problem.
eClinical works.
Yep.
They most of them have this feature if it's turned on for your practice. Most of them have this feature. So you've got to
Yeah.
ask questions about the problem list. And then second, Michelle, one thing that comes to my mind is just the workflow in general. And what I mean by that is when practices are having discussions about the risk adjustment process, do you
Mhm.
come to that group of providers telling them, okay, we want to focus on an annual wellness visit, or you have a focus for every patient coming in for chronic management? What do those discussions look like? What is the expected workflow for maximizing risk adjusted information?
Mhm. Um, so I think if everybody would just only document what they addressed, we'd be golden. If you
Yeah,
document what you do, it's as simple as that, in all honesty. And I just want to say, like, it kind we don't want to blame the problem list. I think the problem list function is very useful. The problem is it's not being used as it's intended to be
right.
used. So you have to get that provider in the workflow of, okay, I've seen this patient. Review the problem list. Are the diagnoses that I addressed there, are they there to the level of specificity supported by my documentation? If
Mhm.
not, you need to review that and possibly update the the problem list. But what it comes down to from a workflow standpoint, in my opinion, is they truly need to just document their actual work of the encounter. I think there's been too many distractions in trying to encourage them to capture as many as possible, where if we just had them focus on what they actually addressed, we'd be a lot better off. And
Well, and here's one of the things, and I don't even know if you're aware of this. I think we may have talked about this a long time ago, but the reality of the situation is that the payers are putting so much pressure. We now have situations, and I don't know how this is legal. I'm not going to begin to even try to approach that. My thought is it shouldn't be legal based on everything we deal with, Stark law, having to worry about anti kickback, all of the relationships that our providers have with other entities. So I'm just going to throw that out there because I think this is ridiculous. I don't think it should be allowed. But there are payers out there that are incentivizing providers by saying, you report this particular, they just pick a code. It's like a dummy code. And they say, you report that and we'll pay you this amount of dollars extra. And that's intended to be for your complete code capture. So when we're seeing that language in this Optum letter talking about complete code capture, talking about
mhm,
completing the patient's health, picture, they're using these words and they're incentivizing providers to try to get the data that they want to get the money from the government.
mhm,
So, yes, it is as simple as only documenting what it is that you're addressing, but now we have
have that.
practices that have this agreement. I don't know if it's in writing. I don't know what those things look like, but I've seen claims and I have friends that own billing companies and they've told me about it where absolutely these arrangements are set up, they report it, and they're getting extra money in one way or another. So when we think about asking the question about workflow, you've got to be aware of that in the practice. I'm
Yeah,
sure
I did
I'm
not know
sure they
about
will
that.
know. Yeah.
That's
Yeah.
that's crazy to me that that
Mhm.
is an approach they are taking. And I also think of this from like the transparency perspective now with
Mhm.
patients' documentation being so readily available to them. As a
Yeah.
patient, I mean, granted, most patients don't know or even think to look to this level of detail. But when I go to the doctor, I expect my conditions to be my health to be their main focus and concern, not how do I get this little extra
Mhm.
pick me up from the payer over here. So if I'm a patient who went to the doctor, and I'm going to say I went to my primary care. We talked about, now these aren't really my conditions, my hypertension, my diabetes, my coronary artery disease, and my hyperlipidemia. Okay.
Hmm.
And then I see a note, and all of a sudden, like, GERD is on there, and,
Hmm.
I don't know, all these other things that maybe it's something I noticed had been brought up at years before. That's really going to stand out to a patient. I know for me or like my husband, when either of us go to to the doctor, the first thing I'm doing when it's over is going in and looking at that chart, because I want to
Hmm.
see what they said happened in that room and compare it to what
Yeah.
actually happened, because I see on a regular basis, and I have to be able to advocate for the proper care and having
Hmm.
the correct continuity of care as well. So you have to think about that. It's not just affecting your reimbursement, but how are you affecting the patient's health? Because once that diagnosis goes in their chart, it's there forever,
Yeah.
whether it's current or not. If you put it in there as an active diagnosis, it's there forever.
Yeah. Well, and again, thinking about pressure, there's another area, and this is something that you also may not be aware of, but another
I'm
area,
learning all sorts of
I
things
know,
today, apparently.
it's just it gets very frustrating. Um, but another thing that payers are doing when they're trying to pressure and incentivize our providers is they're also using this as a form of a way to rate them. So when you were talking about, obviously they shouldn't be thinking about that when they're looking at you clinically and looking at, addressing what it is that's going on. They shouldn't be worrying, oh, I'm going to be rated as a low, I don't even know what category they would put it in. I would hope it wouldn't be low quality,
Yeah.
but it does pair with quality measures, so it's possible it would be something like that. But it's going to affect the way that they're showing up within the network as a provider with that insurance rating. And, that's also becoming problematic because we think about the ways that this type of thing trickles down to providers. And, if this is something new, you've never heard about risk adjustment before,
Mhm.
but you work in the industry, this is why there's so many layers to it, because
Yeah.
it's not something that the providers feel immediately. But when, the payers are hit and they're told that their information is incorrect, it's ultimately because of the documentation that exists compared to the claims data that was submitted. So that is going to be coming from the treating practitioners of those patients. And, the payers are looking for ways they can't do this alone. Look at United Healthcare. They already tried to do it alone with their
Mhm.
own employees going into patients' homes, and that didn't work.
No.
So
But
it continually comes back to that treating provider.
it kind of flips what the encounter with the patient is about. Instead of it being about what the patient, it being driven by what the patient is there to address, it's kind of now expected that the provider beforehand go and look and make this list of possible things that the patient has ever had going on and address them all.
Well, it's funny you say that because some practices put in workflow where, say, a nurse goes in, and this is more so the practices who use the annual wellness visit as a time to capture everything. But there
Mhm.
will be situations where nurses will be going in and looking through everything, almost in like the CDI type of situation, and then looking to grab all of these diagnoses and then put it before the provider and say, okay, only put it in if you address it today. So they'll say, 20 conditions and then put in that they're stable and put nothing else. And again, in claims data, we won't see the diagnosis again. but they're thinking that they're getting it because it's something that was assessed by the provider with the
Yeah.
stability level noted. So, and there's other arguments to that,
So,
because with risk adjustment, we really should have action items along with assessing. But people like to skirt the line and just get one area of meat that you were talking
yeah.
about.
So
So
this
it's bad.
so this makes me think. So I never have really delved into the world of HCC coding, only very surface level, as evident, by these new things I've learned today. But to me, even in HCC coding, even with meat, don't the guidelines still have to apply? Like, we can't just throw the guidelines out the window. So, saying something alone is stable wouldn't documenting it as stable alone within the E&M guidelines would not really consider that as a problem addressed. So, when we're following reporting E&M services, the guideline would not be met to support that as a problem addressed. But also, don't ICD-10 coding guidelines still have to apply as well, as far as the level of specificity that we're reporting things to and things like that? Because
They do. They
they're
do.
I feel like they
They
have to
do,
work
but
together.
this is where people skirt that line. Because if you look at risk adjustment, for example, they say one area of meat. So if they examine a certain, condition through their physical exam, that technically would be one area of meat. If they're addressing it, saying the stability level, it's one area of meat. But the reason this is problematic is because of everything else I've been talking about, where it doesn't hold up to pressure when under audit and looking at,
Mhm.
okay, how is this really something that is being managed for this patient? Who
And
is looking over this condition? Who's making sure that they're remaining compliant? How is it not impacting, hospitalizations? How are they not worsening in the disease process if they're only checking and saying stable once a year, maybe not even doing diagnostic
well, how do
testing?
they know they're stable
Yeah,
at that point? But, like, also, oh, those sirens are really, really loud. There
I
was a
can't
really
hear it.
loud okay, good. There was a really loud train horn earlier, and now these sirens. I live on a busy road and right by a train track where a car got hit not that long ago, so the trains
Jeez.
really blow their horns. Luckily, nobody was injured, but you're not supposed to stop on the dang train tracks, and they do. Gotta
Yes.
get, 3 feet closer to the red light. Um, but as so a lot of times when we're doing audits and we're looking at these encounters, we hear back from the client when we have findings back from the client related to like HCC type reportings. How can a coder, we are not allowed to do any type of assumptions, clinical interpretations. How can we take information from a physical exam and diagnose a patient based
Well,
on
and
that?
you can't, and that's why you see so much of this bad behavior and coding
Yeah,
practices around risk adjustment, because people are just focusing on wanting to maximize. And, that's also why the last question that I think practices should be asking is, who is challenging your risk adjustment process that you have internally?
yeah,
So we always talk about having external audit reviews, but again, this is another example of why that's so important, because if you are just heads down trying to grab everything possible that you can, there are going to be so many more issues down the line when you go through state audits. If
mhm,
you look at things like the PACE programs, risk adjustment is no longer, it never really was focused just in the Medicare population, but we're seeing more and more mention of it now with other age groups and pediatrics, with Medicaid plans, with even some of the commercial situations as well. So with all of this happening, there's just more and more focus on trying to make sure that you are getting it. So, that type of thing just leads to all of the fraud or abuse that's occurring, and it really is
Yeah.
one of those two buckets. Even though people don't like those words, it's a
Mhm.
very tricky situation that people constantly try to push to get more data reported.
Yeah, and would you say that when HCC first came out, I feel like the the coders who focused on HCC had a clinical background. They were RNs. I'm just a hot mess.
Yeah. Well,
Sorry
they
to
did.
interrupt. But weren't they clinically trained like RNs, for example? But now would you say practices are trying to circumvent that need to have that clinical background to be able to identify these things and put it onto coders whose purpose never has been that from the get-go. Like they're
Yeah.
supposed to be two separate functions. They're not supposed to be the same
Well,
or
and
commingled.
that's what leads to a lot of the issues. Some practices that I've worked with, some organizations have people like you and I with no clinical training, but they do expect them to know like lab values that are abnormal and things like that, the way that a disease process would work, and then try to catch it and then bring it to the provider's attention.
Mhm.
With CDI, though, that industry has largely changed over to more clinical, where they want someone with nursing. It
Yeah.
wasn't always necessarily a requirement, but I remember years ago working with a staffing company, and when they were working on CDI positions, they required, a lot of the hospitals required the people to have an RN.
Mhm.
So yes, that's another thing, and we could talk about this all day. I'll end it here on this note,
Yeah.
but that is a part of why staff. So we have insurers putting pressure on our providers, and then we have providers or whatever organizations they're a part of putting the pressure onto staff. And it's where we have all of these breakdowns and disconnects that are causing the issues within risk adjustment. So, overall, hopefully, we've given enough insight today to point out
Mhm.
what I know we have as far as the major problems. But, this is something where I can't stress it enough that you've got to challenge what it is that you have set up. If you're not
Mhm.
getting external reviews at least once a year to make sure that your providers are not going back to bad habits, making sure that you really truly are supporting what you're putting out there, I think it's only going to get worse for providers, because
Mhm.
with my clients, I've seen claims that deny for incorrect specificity, to your point, Michelle,
Mhm.
where, working with a large nursing home population, all of a sudden hundreds of claims are denied because they didn't do the diabetic complication. They didn't
Yeah.
show hypertensive CKD. And just based on
Mhm.
diagnoses alone, the entire claim is denied. We're going to see more of that. This isn't going to go away. And we've got to make sure that we're staying on top of it and continuing to educate. That's all we can do, is get the word out there, try to keep working with our providers, but really making sure that everyone understands why things like this Optum letter are so concerning, and why
Yeah.
you don't just jump on it and submit corrections based on a pseudo claim that they think they have, told you correctly.
Yeah, and just because they're telling you doesn't mean it's right. There's still somebody over them governing what's being reported. So you
Yep.
still can be found non-compliant and you can't say Optum told me to do it and get away with
Right.
it.
Yep. Yep. Exactly. All right. Well, we'll go ahead and end the episode here for today. I did just want to put out one other reminder. Next week, I do have the wound care based webinar events. You can find that on stephanieallardconsulting.com/webinar events, or you can go from the homepage. That's going to be largely based on skin substitutes and what you need to be looking for in documentation. We've seen the UPICs making their way throughout the country in these types of audits. And it's even, one provider practices who chose to treat one patient who are being audited. So it's something that's really important. If you have any involvement in skin substitutes, any kind of wound care practice or department within your organization, you're going to want to check that out and make sure that you're staying on top of that. All right, till next time, I hope you all have a good week.